Allah يعطيكم العافية. I didn't expect that you're gonna have a lecture today after the exam, but yalla, let's inshallah have a light lecture. It's about diabetes and hypoglycemia. So first we're going to talk about the introduction. Of course, you all know that diabetes is a metabolic disorder that is characterized by high blood glucose concentration. And of course, this could be a defect in the insulin secretion, insulin action, or both. And of course, we know that it leads to serious complications and premature death. So we need to have some steps to control the disease and lower risk of complications of diabetes. There is a very important period before the diabetes hit. It is called the pre-diabetes, and it's a stage of impaired glucose hemostasis. And we noticed that during this stage that the fasting or glucose tolerance test is okay. So is it the screen is shared? You can see it? No? You are not sharing the presentation. Oh, I shared the. I put this presentation in the chat. Did you see it here? And I also sharing my screen.
No, doctor, we can't see it.
You cannot see it on the screen. You cannot see it, or you cannot see the shared one, the one I sent you in the
We
chat.
can't see the screen.
Okay, just let me also. Okay, so. Okay, sorry. How can I? You are new share. Okay, this one. Now you can see. Yes. Okay. Okay. Good. Okay. So as I was saying that prediabetes is a stage of impaired glucose hemostasis. So here we have. Excuse me. So here we have a period of a reversible period that we can detect by doing fasting or glucose tolerance test. The results would be above normal, but not diagnostic of diabetes. As you can see here, the pre-diabetes stage is above the normal readings for all HbA1c, fasting blood glucose, or the oral glucose tolerance test. So we can see that this area is called pre-diabetes, in which it's not a full-blown diabetes, but it is impairment in the glucose tolerance. So we should monitor these people, these patients very well, because they are at high risk of coronary heart disease or cardiovascular disease, and also future diabetes. So before, the changes that happens in the blood, the lipid profile is actually great during this period. What I see during my practice, I see that people they don't know about themselves that they do have diabetes, but their lipid profile is high, and especially their triglycerides and LDL level. We'll go back also to the classification of diabetes, and I'll talk later on pre-diabetes more in detail. So the type of diabetes, we know that it can be affected. It can affect the children and young adults, and this is called type 1. And these patients, unfortunately, are dependent on insulin to prevent ketoacidosis and death. And this only accounts for 5 to 10% of the diagnosed cases. While the most common one is the type 2 diabetes, which is usually comes to the older adults. However, we are seeing this now in younger adults and children because of the unhealthy lifestyle. It's a slowly progressive disease, and there are like various treatment, and of course we can like take oral hypoglycemic agents, and not necessary to start with insulin, but eventually these patients can end up using insulin treatment. The complications of diabetes may be present at diagnosis of type 2 diabetes, and that's because of the prediabetes stage. Now we have the gestational diabetes, which is the diagnosed during the pregnancy, and usually it's diagnosed at the 2nd or 3rd trimester. This diabetes requires treatment to normalize maternal blood glucose levels to avoid complications in the infant, such as macrosomia or fat baby, because usually these mothers have big babies when they are diabetic, and unfortunately also these babies should be really screened for diabetes later on, and for obesity, because they are at risk. Now, other specific types, we have like diabetes that results from specific genetic syndromes, could be secondary to surgery, to drugs, to malnutrition, infection, or other illness. Excuse me. Dietitian, as I'm speaking. Wa alaikum salam. So, let's go back to pre-diabetes stage. Is it reversible? Yes, it is reversible. Insulin resistance, and this causes the pre-diabetes stage, that usually the tissues become insensitive or have decreased sensitivity or responsiveness to insulin, and this results in hyperglycemia, and usually in the beginning there is a compensatory increase in the insulin. So when you test the blood insulin level or the serum insulin level, you see that the insulin is high, like the patient is having hyperinsulinemia. This insulin in the blood will try to maintain normal blood glucose concentration, but as the disease progresses, and this can take like years, the insulin production gradually decreases, and the increase in free fatty acids, unfortunately, excess intra-abdominal obesity also appears, and insulin resistance is a central feature for metabolic syndrome. So because the insulin is an anabolic hormone, and it favors the building up of the fatty acids and triglycerides. So we see that patients in pre-diabetes stage have hypertriglyceridemia, and they have like excess fat in the abdominal obesity most. And this is what happens, like the resistance becomes apparent when the receptors in the cell don't really act on the insulin, or don't respond to insulin on the receptors, and therefore the insulin starts to increase in the serum with the also glucose. So it's a vicious cycle, actually. Usually obese patients are at high risk of becoming pre-diabetic, and they have like insulin resistance, and of course insulin resistance will cause the insulin to be produced more, and causing more obesity and more fatty tissues in the body. Now, how can we manage prediabetes? It's only lifestyle changes. It doesn't need to have any medications, but some doctors like to give medications. But there are like two studies that are very, very important studies. They show the effect of lifestyle interventions on prevention of diabetes in high-risk individuals. It's called Finnish and Diabetic or Diabetes Prevention Program. And both of these studies give the same results. The studies actually, they decrease the progression of diabetes by 58% by just lifestyle changes, comparing to 32% for the glucophage. And so here, like, what are the highlights of these studies? The Finnish diabetes prevention study took like 522 middle-aged overweight subjects. So they had to have like overweight body mass index, and also their impaired glucose tolerance. And also they were given intensive instructions. These instructions were to have intensive instructions on weight reduction, to reduce the total intake of fat, to increase fiber intake, like lifestyle and diet management. Also physical activity, the goal is more than 150 minutes per week. So this was the one of the first controlled randomized study to show that type 2 diabetes is preventable with lifestyle intervention. And the risk of diabetes was reduced by 58%, which is a roughly high percentage. And in the intensive lifestyle intervention group compared with the control group. These results have been reproduced in the diabetes prevention program also. The same study, but this time this study were taken from 27 different clinical centers in the USA. And the participants here also were also instructed on intensive individual counseling, motivational support, also the diet, exercise, behavior modification, and the same results also gave us 58% reduction in the risk of become diabetic. Now, while participants who were in the same study and who were only taking metformin, which is the glucophage, we reduced the risk of developing diabetes by 31% only. So this is like half maybe the risk. Now, the lifestyle changes work particularly well also for patients or participants aged 60 and older, reducing the risk by 71%. So, you know, like from these two studies, you can see that really lifestyle and behavioral change are very important in preventing the diabetes, which is a very chronic and very aggressive disease that affects all the body. Now, this is the graph that shows you the study how by the years of randomization, how the 58% only the reduction were 58% by the use of lifestyle intervention, and the metformin is 30, and of course the control group or the placebo group was the highest. Now, let's start with the medical nutrition therapy. Now, from now on, we are going to deal with the medical nutrition therapy when we're dealing with certain diseases or certain health conditions. So what do we mean by medical nutrition therapy? It's defined as nutritional diagnostic therapy and counseling services for the purpose of disease management, which are furnished by registered dietitian or nutrition professional. So it's not a medical diagnosis, it's not a medical therapy, it's a nutritional diagnostic and nutritional therapy and counseling. Now, this is basically what we do and what our roles is in the medical service for the patient. So usually the patient is referred by the physician, and usually it's a written referral for medical nutrition therapy for diabetes, let's say. The referral includes information regarding current laboratory test results, medications, other medical diagnoses, So what we do is we assess the patient. We perform a comprehensive nutrition assessment utilizing the diabetes, of course, or 1 and 2 evidence-based nutrition practice guidelines. We have like a tool, and of course, we ask the patient about their diet history, about their food allergies, about their likes and dislikes, about their GI issues, about, you know, all the things that relates to nutrition. And then we do the initial nutrition diagnosis. For example, we can say in this case, like for the diabetic patients who have uncontrolled blood sugar level, we say inconsistent carbohydrate intake, inconsistent timing of carbohydrate intake throughout the day, and this could be like our diagnosis. And then we intervene. We provide counseling. We with the client. But don't forget. Determines intervention using the cognitive behavior model, including problems. And this is only for you to know or to understand how we are, you know, like doing this in our practice. Of course, we need, of course, all the time to monitor. We give a plan for the patient. We give the counseling. We teach the patient. We put the proper diet if he's impatient, and we give him the proper diet, you know, plan for him, and including all, you know, the portion size and so on. And then we monitor. We give him like follow-up appointments. We monitor the labs. We monitor the weight. We monitor diet. We take like diet history from him again. And this could be like need for changes, our medical nutrition therapy, and also we document all. Through our journey with the patient, we document everything. We do the initial assessment. We do the nutrition diagnosis. We do the intervention. Everything should be documented, and of course, we need also to always use the critical thinking. We review the data from the patient's medical history and other healthcare professionals. And of course, we do all this. We analyze and share in the quality improvement department and implement improvement. So this is basically what we can do, but you don't need to memorize all this. You just need to read it and appreciate what we do with the patients. Now, let's see. So let's first start with the medical nutrition therapy for prediabetes. As I mentioned earlier, the prediabetes doesn't really need to be, the intervention shouldn't be really very aggressive. It should be only like diet changes, should be effective component. This is an effective component of prediabetes management. It could be like lifestyle changes, decreasing the risk of type 2 and coronary vascular disease. And this can happen by encouraging the patient to do more physical activity, promote healthy food choices that facilitate moderate weight loss and maintain weight loss forever. Now, the management of diabetes. Why do we need to manage diabetes? We know that diabetes is linked to a lot of other complications in our body, like the progression of eye, kidney, and nerve damage because of diabetes. Also, we have like clinical trials that have demonstrated clear link between glycemic control and development of complications in person with type 2 and type 1 and type 2 diabetes, as well as the importance of nutrition therapy in achieving control. So the first trial is the diabetes control and complications trial. And this is the link if you'd like to have a look at it. And the other one is the United Kingdom prospective diabetes study. And there is also the link. So we know that microvascular complications, including the diabetes retinopathy, diabetic nephropathy, and neuropathy, this is involving the microvascular complications. Also, the macrovascular affecting the atherosclerosis, which is affecting the coronary arteries mostly, and the arteries of the limbs also. leading to cardiovascular diseases and others, increased tendency of thrombosis, impaired blood flow in arteries increases the risk of claudication and contributes to the development of foot ulcers. So all these complications can be prevented by maintaining normal glycemia. Now, what are the goals of medical nutrition therapy for diabetes? We need to the extent possible, achieve and maintain certain points. Like we have to try to aim for blood glucose level in the normal range or as close as normal as is safely possible. So we know that for diabetic patients, it's very hard to keep them like always on the normal level, but we have like, close to normal as possible. This, if this can be achieved, this would be great. A lipid also and lipoprotein profile also should be low to reduce the risk of vascular diseases. And of course, the blood pressure levels that reduce the risk of vascular diseases. Also, number 2 is to prevent or at least slow the rate of development of these complications of diabetes by modifying nutrient intakes and lifestyle as appropriate. So it all, from our side, it all goes related to the nutrient intake and lifestyle modification to address the individual nutrition needs. We know that diabetes is a chronic disease and it stays once it hit and it's diagnosed as full-blown diabetes disease. So this means that this will stay with the patient for the rest of his life. So what we need to know and understand that these patients have their preference, have their personal cultural preferences. We need to counsel them always. We need to reach in the middle with them, not just restricting things without evidence. We need to give them evidence. We need to encourage them all the time to comply with the recommendation. And as I said, limit food only based on evidence and maintain the pleasure of eating. Now, the amount of carbohydrate ingested has the greatest influence. Of course, what affects mostly the blood glucose level is the carbohydrate ingested. This is the greater glycemic, the greater the glycemic response is, the more is related to high carbohydrate intake. So usually for the diabetic patients, the recommendation is based on the person's metabolic needs. Of course, if the patient is athletic, if the patient is, how old is the patient, what is the type of the diabetes, the degree of glucose tolerance. So all this can be considered when we are planning the diet for the patient. Now, carbohydrate intake must be fairly consistent at meals, and especially for those who are on intensive insulin therapy. This helps to reduce fluctuation in blood glucose level between meals. Now, for those who follow low carbohydrate diets, who restrict the carbohydrate intake to less than 130 grams per day, are not recommended for diabetic patients, and especially for those who are on insulin, because these are at risk of developing ketosis or also hypoglycemia. Now, different carbohydrate-containing foods have different effects on blood glucose level, and this is what is known to have a glycemic effect of food. Now, for example, when we give the patient, for example, a piece of bread, is it a white bread or brown bread? It differs. So there are certain factors affect the glycemic effect of food. For example, the type of carbohydrate, as I mentioned now, is it is it like a starch? Is it sugar, simple sugar? The food's fiber content, is it brown? Does it have the whole grains, or does it have refined grains? Is the preparation method, is it like juices, or are you eating the whole fruit itself? The other food included in the meal also, like are you eating this carbohydrates in combination with fat, with protein, with nuts, with fiber? So all this will affect also the absorption and also individual tolerance to the food itself. So basically, glycemic index is a measure of the effect of carbohydrate in food on blood glucose level. So how much, it measures the relative area under the postprandial glucose curve. So after you ingest the meal, 50 grams of digestible carbohydrate compared with 50 grams of standard food, either glucose or white bread. It estimates how much each gram of digestible carbohydrate in the food raises a person's blood glucose level following consumption of the food. So in other words, like we can say, like I'll give you an example. I'll go back here and explain, because maybe it's a bit confusing to you. We need to compare the food that we are eating, and especially the carbohydrate, the rich in carbohydrate food, to a certain standard. Okay, so what we used here, what is known globally, that the 100, if the food that we are comparing is the glucose or the white bread, because when the person ingest this food, like the glucose, the sugar, which is the pure sugar, or white bread also will be converted to sugar very quickly. So when the person is ingesting like 50 grams of this standard food, the blood glucose level is, or the glycemic index is given the rank of 100, which means that this will raise the blood glucose level very fast. While when we compare this to other foods, like let's say we give the patient a potato, and we found that the potato raised the blood glucose level relatively also similarly to the sugar. So we say like potato is also having a high glycemic index. So each food we are giving, or the patient is eating and digesting, of course, minus the fiber, is the food that having effect on the glycemic or the amount of blood sugar or the serum blood glucose level in the body. So let's say here, glycemic index is high when you have the glucose. This means that whenever you ingest something with glucose or similar to glucose, something that is having high glycemic index, your blood glucose level will be very high. And this is very important to know, because when the patient is having, for example, hypoglycemia, it's best to give him something that is high in glycemic index, because we want him to have hyperglycemia very fast. But we need him to eat something in the usual state to maintain good glycemic control, to have something with low glycemic index. For example, beans are good examples because of the beans, because they contain fiber, they contain protein, and they, like with the investigation and studies, found that they have very low glycemic index. So they don't really raise the blood glucose level as high as the glucose. See how is the difference very significant different in the raising the blood glucose level. At the beginning, it's very steady and slowly, and then it goes up, but it's not up a lot. Like it keeps on the same acceptable level. Here it is like when we multiply it by 18, it's going to be more than 100. Let's say I'll do the multiplication. Like if we say 7 multiplied, like 126. So like it's even more, it's even like 150 or 160. So here it's not even close to 100. So that's why we always prefer the low or medium or moderate glycemic index food. Now, when do we give the number of, or when do we name the food low, having low glycemic index? When the number given is below 55, and between 55 to 69 is considered medium, and above 70 is considered high. Of course, these numbers, where can we find these numbers? These numbers can be found in charts online. You can find them online on all, like diabetic sources, online sources. You can look, and of course, as I mentioned earlier, like the glycemic index of food can be different. Like maybe like the same food, but how it's prepared with the glycemic index will be different. If there is anything else with the food, also the glycemic index will be different. So, like we need really to know exactly what affects the glycemic. And after all, some patients react differently, like some patients, this food, sometimes I visit patients, they tell me that yogurt raised their blood glucose level more than milk, for example, or so, like individual tolerance also play a role here. Now, so as I said, like what do the numbers mean? Eating pure glucose is given a ranking of 100. All other foods are in relation to this. So a food with a glycemic index of 95 raises blood glucose level almost as much as pure glucose. So 95, 80, 85, 70, 75, it's all the same, like we consider them high glycemic index. But a food with a glycemic index of 20 doesn't raise blood glucose level at all. Now, also, we have something else that need to be also taken into account, that the glycemic index doesn't take portion size into account. The actual amount any food raises blood sugar level has to do both with low glycemic, with how glycemic it is and how much of this. Like, even though you are taking something with low glycemic index, but if you're taking it a lot, like in portion, a large portion, maybe this will lead to hyperglycemia because the glycemic load is high. So also that, like, scientists came up with this thing, which is the glycemic load, that attempts to combine these concepts, and some diets are using the glycemic load for this reason. I'm just telling you this because you need to know when you like hold a package of biscuit or a food, and you read or you are reading a study, and you need to know what we mean by glycemic index and what do we mean by glycemic load. So now you understand that glycemic load is amount of carbohydrates, not only the type of carbohydrate, it's the amount of carbohydrate in the food adjusted for its glycemic potency. And there is like an equation here to know, but you don't need to memorize, because this is not your job to know, that how to calculate the glycemic load. But I just want you to know and to be familiar with these terms: glycemic index, glycemic load. When you consult your patient, how to lead them, how to tell them, how to advise the food, the different foods, and you can tell them about this, that the food is sometimes causing your blood sugar to be up. Now, just for to test your knowledge, or you're guessing, maybe it's something to guess. What is the glycemic index of banana? A lot of patients think that fruits are not allowed for patients, for diabetic patients, because fruits have sugar. Well, according to the glycemic index, one banana includes 56. The glycemic index is 56. So this means that the banana doesn't really have a high glycemic index. It's considered like, when we go back here, it's considered in the medium stage. So it's not really bad. Just excuse me, please. Dietitian Razan speaking. Hi, Arvik. Yeah. It is. Mm-hmm. because this patient, I changed his formula for like many times now. I gave him the Nutrizone. You said he had hypoglycemia, or he had, I don't know. Shall we go back to Nutrizone? We can go back to Nutrizone if you have it. Yeah. Nutrizone multifiber or Nutrizone Protein Plus. Yeah, Nutrizone Nutrizone Protein Plus is better. Okay, and he was on 40. We'll put him on 50. Yes. Okay, I'll put the communication for you later. Okay, you're welcome. Bye-bye. So am I mute or I can't see? You hear me? I'm not mute, right? Okay. Type. So eating pure glucose is given a ranking of, yeah. So here, as you can see, the banana has 56, which is considered moderate. The glycemic index of when baked potato is high. Why? Because potato is mostly, especially if you're not taking it with the skin, it's considered starch and very similar to the bread. So it's having a high glycemic index. Causing a high, fast blood glucose to rise. What is the glycemic index of one medium apple? Apple has low glycemic index, by the way, so it's always, a good snack for diabetic patients. And this is for your information if you'd like to know the glycemic index of food. Okay. And again, this is for your own knowledge and information. You don't need to memorize these, but it's very important to know what is the glycemic index. What do we mean by glycemic index? Now, the American Dietetic Association recommends the following. The carbohydrate intake should emphasize nutrient-dense carbohydrate sources that are high in fiber. As you can see here, all these choices are high in fiber. We are aiming for whole grains, like always have the bread and rice and pasta, oats to be whole, fruits, vegetables also to eat them by themselves, not to have them juiced without the fiber. The seeds, the nuts, also dairy products are a good source of carbohydrates because remember the lactose is disaccharides that has sugar, like the milk has lactose, and they provide also like 12 grams of carbohydrates. Now, so this is for the carbohydrates. For the fiber, recent studies have controversial opinions about the link of fiber intake and beneficial effects. No, it doesn't raise blood glucose level. Yeah, glycemic index of 20 doesn't. But again, I'm telling you that you need to take into account what the glycemic load. Are you taking a lot from this food? Is there how you are taking this food? Is it like let's give you an example. If we say the apple has 20 or has 30 or I don't remember whatever the number is, but it has like low glycemic index. Let's say that the apple is not eaten as itself, apple with the skin and so on, but it was consumed as juice. So when you consume it as juice, the glycemic index will be different then. It won't be the same as, apple by itself. So this is very also important to take into account the factors that is listed earlier that I read it, okay? Now, a lot of we can usually recommend for the patients to have we recommend for the patients to have fiber, but there are controversial studies or opinions about the link of fiber intake and beneficial effect of glycemic control, because having the fiber in the food with the starch, for example, it will reduce the absorption of or the fast, like the time, it won't make it very fast absorbing the blood glucose. So the study compared 24 grams of fiber a day with 50 grams of fiber, reported improved glycemic control, reduced hyperinsulinemia, and decreased plasma lipid. So it's good, like, you know, to have always a good amount of fiber, like at least 24. As for the general population, it's always recommended that diabetic patients are encouraged to choose variety of fiber containing foods, like the food here I showed you. It's very high in fiber, and it's very much recommended for diabetic patients. Now, the healthiest sources of carbohydrates, unprocessed or minimally processed whole grains, vegetables, fruits, beans, promote good health. And of course, will deliver vitamins, minerals, fiber, and host of important phytochemicals. Unhealthier sources of carbohydrates include white bread, pastries, sodas, other highly processed or refined foods. These items contain easily digested carbohydrates that may contribute to weight gain and interfere with weight loss and promote diabetes and heart disease. Now, what about sugars or sweeteners? Are they allowed to have sugars? Are they allowed to have sweeteners for the diabetic patients? There is a common misconception that people with diabetes need to avoid sugar and sugar-containing food. However, available evidence from clinical studies showed dietary sucrose has no more effect on glycemia than equivalent caloric amount of starch. In other words, like, we're not promoting, of course, the intake of sugar, but we're saying that, you know, don't be mistaken, like, okay, you are preventing or you are restricting the sugar, but again, you have to know that when you are ingesting the starch, you are also having the sugar in your blood raised, because the starch is directly converted to sugar. So and start yani from the mouth, it will be converted to sugar. So that's why we need always to tell the patients that you need to really know that what raises your blood sugar. So it's okay if you are like taking 1 teaspoon of sugar, it's okay, because it is important to note that excess energy intake from nutritive sweetener or foods and beverages containing high amount of nutritive sweeteners should be avoided. Of course, that's what I'm telling you, like the sugar, anything that that contribute to the sugar or the energy, this should be avoided, since they provide empty calories and can lead to weight gain also, especially for like sodas and juices. The amount of sugar is really empty calories. The amount of calories they provide is empty, because they are like empty from any nutritional value. We know that fructose has a minimal glycemic effect because it has a different metabolic pathway. And it has a sweeter taste. So when we take it, we don't need much of the sugar, because it gives us the sweetener or the sweet taste. But it's not advised, according to evidence, it's not advised to be consumed, because it has an adverse effect on selective deposition of ectopic and visceral fat. And also it can lead to lipid metabolism, like altered lipid metabolism, blood pressure, and insulin sensitivity. And this is also compared to glucose-sweetened beverages. So I don't know if like some patients refer to fructose as a sweetener. They say it's better because it's natural, it's from fruits, let's use it instead of sugar. But according to the studies, it's not really advised to have fructose as a sweetener. Thus, recommendations about the optimal amount of dietary fructose remain controversial due to potential metabolic consequences. As I mentioned, it has a different pathway in the metabolism, and that could lead to further insulin resistance and obesity. Now, non-nutritive sweeteners, remember, I don't know if we talked about this before, or this is the first time. Yeah, FDA-approved sweeteners found to be safe when consumed within FDA acceptable daily intake, which is the sucralose, which is known as Splenda, The saccharin, maybe like sweet and low or sugar twin. Asulfame, like asulfame K. I don't know if it's found here, but we have here the aspartame, known as equal NutraSweet. Of course, aspartame need to have a label of phenylketone uric, or like because it contains the phenylalanine. So patients with the PKU should avoid products containing the aspartame because, of course, they have a limited intake of phenylalanine. Stevia also has a reputation of, a good sweetener nowadays. We have also something new, Guo, which is the most recently approved grass, which is generally recognized as safe. And this is the list of the sweeteners. Of course, you don't need to memorize them. This is for your own information. Now, the dietary fat for diabetic patients, evidence is inconclusive for an ideal amount of total fat intake for people with diabetes. Therefore, goals should be individualized, of course, like according to the lipid profile they have, according to the level of activity, the age, the gender. Maybe the gender doesn't really account, but like we can individualize the requirements accordingly. Fat quality appears to be far more important than the quantity, and this is true. Remember when I said that the like certain foods raise the LDL level more than certain food or certain fats. So people with diabetic are considered at high risk of developing cardiovascular diseases. And the guidelines for dietary fats are similar to those for other persons at risk of cardiovascular diseases. So it is recommended always to reduce the fat to 20 or 35% of total calories, like between 20 to 35%. Usually we take the average of 30%, but don't exceed that. Saturated fat intake should be limited to less than 7 to 10% of total calories. So basically, we have to really limit the saturated fat. Use the fat-free or low-fat dairy products and cheese, and also the meat should be trimmed from fat. The chicken skins should be removed. What else? Stay away from butter, from qishta, from all the creams, all the the saturated fat, basically in the animal sources. Now, trans fats intake should be eliminated altogether. And I explained about the trans fats, how it comes from the hydrogenated or partially hydrogenated vegetable oil. To lower LDL, also energy derived from saturated fats should be replaced with either mono or polyunsaturated fatty acids. For example, like instead of using butter to put on the bread, use olive oil, or use any other, or replace the cooking, not using, for example, butter or ghee, and using the canola oil in cooking. Eating one or more good sources of omega-3 fats every day, like fatty fish, walnut, soybean oil, ground flax seeds or flax seeds, oil foods rich in omega-3. So omega-3 is also protective to the heart, as you know that it is anti-inflammatory. So it is good for the blood vessels, also the heart vessels or coronary heart. Now, the protein requirements for diabetic, like the general population, usually we refer to the requirements as 15 to 20% of total calories, or 0.8 to 1 gram desirable body weight per kg. Now, the small short-term studies suggest diet with higher protein intake may improve glycemic control and increase satiety and help with weight loss. However, long-term effects of such diets on diabetes management and complications are unknown. So it's not really advised to, to give a high protein recipe or high protein recommendation for patients, for diabetic patients. In subjects with type 2, it has been demonstrated that moderate glycemia can contribute to an increased turnover of protein, which suggests an increased need for protein. In other words, like these patients are like hypermetabolic, or like, you know, they are in need of important protein and adequate protein at least. Because being diabetic, they are at risk of protein malnutrition. Now, protein in nephropathy, of course, when they have like nephropathy, the similar recommendation for protein requirements should be 20% of the energy, and should not exceed the 20%. And usually what we can do is to give between 0.8 to 1, even 1.1 sometimes it's okay per kg. Intake of protein in the usual range doesn't appear to be associated with the development of diabetic nephropathy. So even if the patient is having like a CKD, giving the adequate amount of protein doesn't really interfere with the disease. However, the long-term effect of consuming more than 20% has been determined, and therefore it may be prudent to avoid protein intake of total calorie intake, like not to exceed protein a lot, especially if this is for long term. Now, micronutrients, the micronutrients recommendations for people with diabetes are the same for the general population. They should be educated about the importance of consuming adequate amounts of vitamins, minerals from natural food sources, as well as the potential toxicity of megadoses of vitamins and mineral supplements. So we always need to have them from natural sources. It's better than having them from multivitamins unless deficiencies occur. Some studies suggest chromium supplements can improve glycemic control in type 2 diabetes or diabetics. However, results have not been consistent with chromium supplementation, and it's not recommended for now. Excessive doses of certain vitamin or mineral supplements when there is no deficiency has been shown to be of no benefit and may even be harmful. There is some evidence that those on metformin therapy are at high risk of B12 deficiency and may need vitamin B12 supplementation if test indicates deficiency. Usually, the intake of metformin, which is known as glucophage, is associated with vitamin B12 deficiency for most people. So it's better to test them like yearly and check their level, and if they need supplementation, usually it is given like intramuscular. This is also a good like nutritional recommendations for individuals with diabetes if you'd like to know more about it. Now, the meal planning strategies. How can we plan the diabetic meal? Now, the dietitian provide a number of meal planning strategies to help people. We have, of course, we take into account the control of carbohydrate intake and also the portion size. Because as we mentioned earlier, not only the carbohydrate type, but also the portion, the glycemic load. Now, carbohydrate intake should be spaced evenly throughout the day. Carbohydrate counting is the one method to calculate the carbohydrate, and also the exchange list for meal planning is another method. Let's start with the carbohydrate counting. It's actually a technique that are simpler and more flexible than other menu planning approaches and are widely used for planning diabetes diets, and this is now used much more with the intensive insulin therapy, because for example, when patients are having insulin pumps, they can count the carbohydrate that they are taking in this meal, and then injecting the insulin needed according to the amount of carbohydrate intake. Excuse me. Dietitian, as I'm speaking. طيب، بس أنا معاكي، أنا اليوم عندي محاضرة هلأ، معلش تكلميني بعد الساعة 3. أوكي، أهلا بابا. So how does the carbohydrate counting work? First of all, the dietitian determines person's nutrient and energy needs. We do the total energy requirements. We do the percentage of carbohydrates from the person, from the total amount of calories. For example, the carbohydrate allowance is divided into portions. And then the portions are allowed, like also we divide the portions according to the meals. So we tell the patients, like for breakfast, you can have 3 carbohydrate portions. For lunch, you can have 4 carbohydrate portions. For dinner, you can have 4 carbohydrates, and so on. So the user of the plan need to be concerned about the meeting carbohydrate goals and can select from any of the carbohydrate containing or carbohydrate counting food groups when planning meals. So in other words, he doesn't really need to be really focusing on protein and fat, but of course he needs to be focusing on the type of fat, on the type of good protein intake and so on. But here we are dealing with mostly carbohydrate to maintain normal glycemia. More guidance is needed for the non-carbohydrate, as I mentioned, like he needs to have a healthy diet, of course, that improves blood lipids or energy intake. Now, how can we use the carbohydrate counting in clinical practice? We determine an appropriate carbohydrate intake and suitable distribution pattern. For example, a person consuming 2,000 calories a day, the carbohydrate allowance is 50%, let's say. So to make it easier, 1,000 calories should come from carbohydrates. So 1,000 calories, how much this is expressed in grams? We multiply, of course, 2,000 by 50%, 1,000, and 1,000 we divide them by 4, which means because 4 calories, and this means that 250 grams of carbohydrate a day is allowed for this patient. Now, 2,550 grams of carbohydrates. Now, we know that each portion of carbohydrate roughly is 15 grams. So when we divide the 250 by 15 grams, which is equal to 1 portion, this means we can allow 16 or almost like 17 portions of carbohydrates per day for the patient. So he can spread these 16 or 17 portions throughout the day. Now, the distribution is among meals and snack, and this is based on both individual preferences and metabolic needs. Maybe the patient is like athletics, maybe he's having a high physical activity level, maybe he prefers to have like a big breakfast, maybe he prefers to have a big lunch. So we can play with the distribution as needed. Now, in type 1 diabetes, the insulin regimen must coordinate with the individual's dietary and lifestyle choices. Like I said, the insulin regimen has to play a big role in the deciding the diet plan. So people using conventional insulin therapy must have a consistent carbohydrate intake from day to day to match their particular insulin prescription. So the conventional is the usual, like the one tablet of insulin, or not tablet, I mean 1 injection of insulin with a conjunction, maybe with the metformin. So maybe they are like taking something with like long acting. So we need to have always a stable amount of carbohydrate throughout the day, and the same from day to day. Whereas those using intensive therapy, what do we mean by intensive? Intensive is like we can play with it. Like we can inject like a pump or like a multiple injection throughout the day. So this is, we can play with the carbohydrate intake, and we can change it. Now, people with type 2 diabetes are encouraged to develop dietary patterns that suit their lifestyle and medication schedules. What do we mean by type 2 diabetes? We mean that they are not now under insulin treatment. They started one on metformin and lifestyle changes. So we can they can follow a dietary pattern that goes well with their lifestyle and also with their medication. under supervision, under medical supervision. Of course, the success with carbohydrate counting requires knowledge. So it's not easy. At the beginning, you need to sit with the patient. You need to inform the patient about all the food sources of carbohydrates. You need to let him understand the portion sizes, the portion control, how he, count and how he match the insulin units with the portions of carbohydrates he's having. So this is a sample carbohydrate distribution for a 2,000 calorie diet. Remember, we use this sample, like 2,000 calorie diet needs at least 50% of this should come from carbohydrate. So here we are focusing on 1,000 calories coming from carbohydrate. And if we divide this by 4, we can transfer them we can do them in grams. So the grams would be 250 grams, 250 grams. And then we can spread the grams into meals. Like for breakfast, 60 grams, which means 4 portions. For lunch, 60, for afternoon snacks, for dinner, for snacks. So this is very good in good, balance between meals. As I said, it requires instructions, it requires practice in portion controls using measuring cups, spoons, food scales. And of course, when using packaged foods, we need to check the nutrition facts panel to find the carbohydrate content of serving. For example, here, you need to teach the patient how to know what is the serving size in the package. Let's say he's having like a package of biscuit. How many servings in this package? Because if he eats the whole package, this means that, like here it says the serving per package or per container is 2. So if he takes the whole package, he's having double from everything. Because there is 2 servings, and usually the amounts here listed or the values listed is only for 1 serving. So the amount per serving is 250. But when he eats the whole package, this means he ate 500 calories. And this means he took 62 grams of carbohydrates. And this means he took 10 grams of sugar, So he should know how to read the nutrition facts. Now, the other, so this is for the carbohydrate counting. The other method is called portion size okay, no, this is just also to know to teach the person on the portion size and the amount of carbohydrate in each carbohydrate-rich food. So basically, we have the food groups that have carbohydrates are usually grains, fruits, vegetables, and dairy. While fat and meat or protein don't have carbohydrate. Now, the bread, cereal, rice, pasta, each portion has 15 grams. And these are the examples. Like when we tell the patient, you can have the freedom to choose from this list in the breakfast, for example. Instead of having bread, you can have tortilla, you can have unsweetened cereals, you can have cooked rice or cooked pasta, not even like for breakfast or for any meal. For the fruit, 1 portion equals 15 grams, which means 1 medium fruit or 1 small banana or half cup of unsweetened fruit juice. And also for the milk or milk products, we have 1 portion equals 12 grams, which is roughly rounded up to 15. 1 cup of milk is either whole or low fat or fat free. Always recommendation for low fat and fat free for diabetic is better. 6 ounces of yogurt means like 200 or to 240 grams of yogurt, the small box. Starchy vegetables, like 1 portion equals to 1 small potato, half cup of canned or frozen corn, 1/3 cup of baked beans. So as you may know, like these all is very good, and you can find them online also. They're like in Mayo Clinic, they have exchange lists for diabetic patients. They listed everything, even the cooked foods and meals and ready to eat like meals. Everything like sweets, and all the food that you can think of, they have like portions for them. And this is especially good for patients following carbohydrate counting. Now, also it is good for patients following the exchange list for meal planning, but the exchange list for meal planning is also broader because it can take into account the protein and fat also exchanges, not only the carbohydrates. Any food on the list can be exchanged for any other or on the same list. Like let's say we recommend 2 exchanges from meat. You can go to the list for the protein or meat, and you can choose either fish, chicken, eggs, tuna, anything that has in the list, because they are very similar in amount of nutrients and energy. So if you like take something instead of something within the list, you will end up having the same amount of nutrients and calories. Of course, to apply the system successfully, users must become familiar with the specified serving sizes. So here is the food list. It is this is the list we have. Like these are the main category, the carbohydrate that includes underneath the starch, and then fruits, milk, and all of this are like considered carbohydrates. And then we have the meat, and then we have the fat. So the main, like 3 main categories: carbohydrates, meat, and fat. The carbohydrate includes starch, include fruits, milk. Why we call them carbohydrate? Because all of them contain some kind of carbohydrate in them, like sugars or starch. For example, bread, fruits, milk, it has, you can see here the amount of carbohydrates in them. While if you look at the meat and meat substitute, you find 0. You find 0 carbohydrate in these. Therefore, we didn't use this method in the carbohydrate counting, because as the name implies, it is only carbohydrate counting that we are dealing with. But if we choose to have the exchange list for meal planning, we choose this, which take into account all the food groups, including protein and fat. So here you can see, for example, like the protein content of some food also, like protein is missing in fruits, but it's missing in fats like oils, but it's not missing in all other food choices. Fat is missing in fruits, missing in non-starchy vegetables like green leafy vegetables and all the other vegetables like salads. And of course, it can vary in the plant-based proteins like beans, like lentils. If you're not adding any oil to them, they might be 0 in fat. So this is basically, you know, the food, the exchange. Now, to which group does cheese belong? A lot of people are mistaken when we come to this question, because they think that cheese belongs to the dairy. However, cheese is high in protein and fat, so grouped with meat, not milk, because they contribute energy from protein and fat and provide negligible carbohydrates. So it's like contrary to the milk, cheese don't have this amount of carbohydrate. Maybe negligible amount of carbohydrate is found in cheese. Maybe it's higher in protein and higher in fat. So it's considered like meat. We consider like 1 exchange of cheese is equal to 1 exchange of medium fat or high fat meat, having 7 grams of protein, and it might be like 8 plus grams of fat in 1 exchange. Okay. Now the insulin therapy, now we know that insulin therapy is required for people with type 1 diabetes, and of course for those with type 2 diabetes who cannot maintain their glycemic control. Eventually, after being for long years on anti-diabetic medications, diet and exercise, they end up taking insulin, unfortunately. The pancreas normally secretes insulin, relatively low amounts. This is, I'm explaining how the insulin therapy works. Usually, they try to or pancreatic secretion of insulin. So this is usually the low amount that is continuously secreted by the pancreas is called basal insulin. And in much higher amounts when the meals are ingested, when it is ideally the insulin treatment should reproduce the natural pattern of insulin secretion. So that they try to imitate the insulin production in the natural insulin production. So we need to know this in order for us to deal with the patients when they are using the insulin therapy. Now, the type 1 diabetes is best managed with intensive insulin therapy. Nowadays, they're using more and more intensive insulin therapy, which involves multiple daily injections of several types of insulin or the use of insulin pump. Now, the regimen that include 3 or more injections allow for greater flexibility in carbohydrate intake and meal timing. Therefore, we need to know what kind of therapy the patient is on in order for us to plan their diet and to plan their diet plan, whether to use the carbohydrate counting, whether to use the fixed carbohydrate distribution among the meals. With fewer injections, the timing of both meals and injections must be similar from day to day to avoid periods of insulin deficiency or excess. Now, a person using intensive therapy must learn to accurately determine the amount of insulin to inject before each meal. Before each meal, you have to look at your meal and know exactly how many grams of carbohydrates you are taking in order for you to inject the amount of insulin, the units of insulin. So this will affect, of course, this is dependent on the pre-meal blood sugar level. Also, we advise the patient to test their blood glucose level before the meal to see if there is like a hypoglycemia. So there will be a correction. And then the carbohydrate content of the meal, and then the person's body weight and sensitivity to insulin. Well, for the initial treatment of type 2 diabetes, this may involve diet therapy, physical activity, and oral anti-diabetic medication. So now, in the beginning, we don't really need to give insulin. However, long term, as I said, it may progress to that pancreas will never or will no longer produce enough insulin, and we need to replace it by exogenous insulin therapy. Approximately 27% of people diagnosed with type 2 diabetes are treated with insulin therapy. And some person may be treated with insulin alone, whereas others may use insulin in combination with other anti-diabetic agents. So I see patients like using both, using the anti-diabetic agents like oral hypoglycemic agents together with the insulin. Now, insulin therapy and hypoglycemia. Now, hypoglycemia is the most common complication of insulin treatment, although it may also result from the use of some oral anti-diabetic drugs, but we see it usually in the insulin mostly. How to correct hypoglycemia? We need to be corrected immediately. We need to take something with glucose or carbohydrate-containing foods. Usually, we give 15 to 20 grams, which is usually equal to 1 portion of carbohydrate. If you remember, 1 portion equals to 15 grams of carbohydrate. This can relieve hypoglycemia in about 15 minutes, but patients should retest after 15 minutes and test again in case additional treatment is necessary. Maybe he has very severe hypoglycemia and it's not yet corrected. Now, foods that provide pure glucose yield better response than food that contain other sugars, such as sucrose or fructose. So it's better always to have like pure sugar, not chocolate, nothing that has fat with it or any other food with it that delay the absorption. Now, people using insulin are advised to carry glucose tablets or source of carbohydrates that be easily ingested. What about physical activity? Regular physical activity can improve glycemic control considerably and is therefore a central feature for diabetic management. And this is usually why? Because it improves the insulin sensitivity. Even patients with type 1 diabetes, they are we see like a better HbA1c when they are doing physical activity, and this should be regular. Also benefit for aspects of health, including blood lipids level, blood pressure, body weight, cardiovascular functioning, and prevention of cardiovascular diseases. Now, the diabetics should undertake at least 150 minutes of vigorous activity each week. In addition, they should participate in a resistance exercises. Why? Because these patients are, as I said, they are catabolic. Like being diabetic is a catabolic disease that eventually the patient starts to lose their lean tissue, lean body tissue, lean mass. Or lean muscle mass. So it's better to always, engage in resistance exercises programs to target the major muscles. What about the gestational diabetes? This is the end of our lecture. A woman with gestational diabetes who are overweight or obese may need to adjust their energy intake during pregnancy. Now, modest calorie reduction. Usually, we tell the mother to reduce her calories by 30% from her total energy needs, because this could lead to improvement in her glycemic level. And the carbohydrate restriction to about 40% of total energy intake can improve also the blood glucose level after meals. So usually we notice that carbohydrate is usually poorly tolerated in the morning. Therefore, we restrict the carbohydrate to only 30 grams at breakfast, like only 2 portions of carbohydrate is allowed in the breakfast. The remaining of carbohydrate should be spread or spaced throughout the day in several meals and snacks, like small frequent meals is always better, including evening snacks to prevent ketosis during night. Always we advise that aerobic activity helps to improve glycemic control for pregnant women. And of course, for women who fail to achieve glycemic goals by diet and exercise alone may need to use insulin or anti-diabetic drugs. So this could be recommended by the doctor to initiate the insulin treatment in order to control the blood glucose level for the pregnant mother. Now, gestational diabetes is a risk factor for developing type 2 diabetes later in the life. So that's what you should tell the mother, that she should be careful after delivering, because even though she's relieved from diabetes after delivery, but she is at risk of developing type 2. So if she kept her weight normal, and if she kept her diet normal or like healthy, she can prevent having diabetes later on in life. So this is basically the lecture today, and if you have any question, I'm glad to answer you. Is there any question, or khalas? It's only 122 participants. Okay, you're welcome, dear.